Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. Welcome to 10 Clinical Minutes. I'm Brianna, and today we have part 2 of our narrow complex tachycardia series, where we're going to be focusing on regular rhythm. So again, quick credit made clear, this presentation was inspired by the same one as part 1 of the series that was presented at the HM20 virtual conference by Dr. Megan Mary Walsh on August 13th, and all the EKG examples are from Life in the Fast Lane. Again, we're breaking it down. The big branch that you need to figure out when you have a narrow complex tachycardia is this regular or irregular? And each of those then has its branching differential diagnoses. And again, quick run through of some things we talked about last time. If your patient is hemodynamically unstable, you need to figure out if it's sinus or not. If it's not, cardiovert them. If it is, treat whatever's going on. We're focusing on hemodynamically stable patients where you want to examine the EKG to figure out what exactly is going on. And if you need to slow down that rate to do so, do what you need to do. Common medications used to slow down that rate. And then we're back to our big 3 questions. Is this rhythm regular or irregular? What is going on with that P wave? And what is the pattern of the rate variation? So again, today we're going to be focusing on the regular rhythms. So let's start out with if P waves are present. First off, we've got sinus tachycardia. There's something going on systemically that is causing the heart rate to go rapid, but it's not actually an arrhythmia in and of itself. So this is a regular rate. It's normally greater than 100 beats per minute is kind of the standard definition of tachycardia. And you'll see this gradually climb as whatever is going on with the patient is progressively worsening or getting better, whether it's anxiety or sepsis or whatever. Sometimes you got to be careful because the P wave will be hidden in the preceding T wave. If the rate is fast enough, they'll be so close together that it's hard to discern that P wave. This will cause what's commonly called a camel hump appearance. So if you look down in this example in lead 2, you kind of have, rather than a T wave space and then a P wave, you have kind of this gradual hill. And what that is in reality is the combined T wave and P wave that are too close together for the EKG to be able to distinguish them. And so it turns into just one larger hump. For the treatment of sinus tach, you got to figure out what's going on. If you treat the underlying cause, the tachycardia will improve. If you need to rate control in the meantime, you can use our typical go-tos, the beta blockers, diltiazem, or verapamil. Next up is atrial tachycardia. This is when tachycardia is originating in the atria, but not at the SA node, so not at the typical start point of the electrical impulse. In this situation, the rate tends to very quickly jump from the normal range into the 130s to 140s, as compared to when we talked about sinus tach, where it was kind of a gradual increase. One of the kind of clinical clues or pearls that you can look for atrial tach is a patient with a heart rate that's pretty high in the 140s, but they actually kind of look okay. On the EKG, you'll find P waves that are present, but they'll look abnormal. So there'll be something wrong with them, but you will have an isoelectric line present, as opposed to like an AFib where you wouldn't have an isoelectric line. So in this situation, look for these P waves that look abnormal. So again, if you compare like in that lead 2, you can see that that P wave is inverted. And then if you look over on AVL, the P waves actually look kind of normal. So you're looking for some instance where the P wave looks different and the heart rate jumps. Treatment for this, again, you got to treat the underlying cause. One common cause of atrial tach is an abnormal potassium, so take a quick look at that BMP and see that potassium level. If the patient is hemodynamically unstable or they're in acute distress, you can do what we talked about earlier with the vagal maneuvers, the adenosine, the blockers, the amio. If this is a chronic problem and the patient has symptoms from it, you can do beta blockers, catheter ablation, or amiodarone, similar to the irregular rhythms. Next, we're going to look at instances where the P wave is inverted after the QRS. So there's 2 situations we need to talk about with this one. First is AVnRT or AVRT, aka SVT. So that's a lot of acronyms. So that stands for AV node reentrant tachycardia, AV reentrant tachycardia, or it's commonly just called supraventricular tachycardia. Now, technically, all neurocomplex tachycardias are supraventricular tachycardia. That's the definition, is that the electrical impulse starts above the AV node, which is why the complex becomes narrow, is because it then goes through the His-Purkinje complex. However, in common jargon, when someone talks about SVT, they're typically talking about AVnRT. So in this situation, the heart rate will suddenly go from normal up to 180 to 200 beats per minute. And then you'll see a retrograde P wave after the QRS, or sometimes it's even buried in the QRS because, again, they're so close together because this heart rate is so fast. What's happening is that you have a re-entrant pathway that's going through the AV node. And that's why you get this retrograde P wave, because it's traveling back up through the AV node, back through the atria in the opposite direction. You'll sometimes see some diffuse ST depression in this situation, but it doesn't necessarily mean ischemia. And this is a very complicated type of arrhythmia. There are many different types, many different causes. If you're interested, go ahead and do your own research into this. It's very interesting, but way out of our scope to go too deep into it. So here I have two examples. In the first one, the rate's about 135, and you can see these retrograde P waves that are happening after the QRS. And the second one, the rate's a little bit faster at 220, and you can see how it kind of gets difficult to distinguish the P waves when the QRSs are so close together. And so in this instance, the P wave is actually buried within that QRS, and you see that ST depression as well in this second example, but that doesn't necessarily mean ischemia. What's the treatment? There's a lot of different treatments. Again, if you can identify an underlying cause, you need to treat that underlying cause. If they're acutely unstable or acutely symptomatic, you can do any of the different medications we've talked about before to try and control that rate or that rhythm. And then chronically, if you're not able to ablate whatever's going on, if they're not symptomatic, it's not a big deal, especially if they're infrequent episodes. They need to see a cardiologist and be followed. But if they are symptomatic, then you do the typical things. We're creating a pattern here. You can use your beta blockers, diltiazem, verapamil. You can ablate it if the cardiologist can identify a particular nidus, or you can use an antiarrhythmic like amiodarone. But again, this is something that is not particularly going to harm the patient if the episodes are infrequent and they're asymptomatic. Next up is accelerated junctional tachycardia. This happens when the AV pacemaker actually overtakes the SA node. So in this case, you'll see a rate of about 100 to 120. So it's just barely tachycardia. And you'll see retrograde P waves again, but this time it's before or after the QRS. And it's a similar case where it's just retrograde conduction through the atria from the AV node. And if you're going in the opposite direction, the EKG reads that as the opposite of what would be normal. So if normal is up, then the EKG will read it as down. You'll also see a shorter PR segment telling us that this is the AV origin and not in the atria itself. Because it's so close to the QRS, it's going into the atria and the ventricles at the same time, and so that PR segment is going to be very short. So you can see in these instances, the P waves are retrograde, meaning that they're negative, where normally we would see a positive P wave in these leads. And then you can also see that that PR segment is almost non-existent. Our P wave pretty much goes straight into our QRS, and that's because the electricity is starting out from the AV node, and then it's going to the atria and the ventricles at almost the exact same time. Treatment for this, again, similarly to everything else. Acutely, you can do vagal maneuvers. It's pretty rare that you have to use these other medications, again, because the rate is only 100 to 120, so it's not actually that fast. And if necessary, you can use amiodarone. More chronically, similar to other instances, if there's no symptoms, you really don't need to treat this unless it's causing other problems in the patient's heart or downstream effects to organs of any sort. But if you do need to treat it, if they do have symptoms, you can use any of the techniques we've talked about, any of the medications, or ablating it if you know the particular location of the cause. Lastly, we're going to talk about if there are no P waves and you see that sawtooth pattern, and we all know that buzzword, sawtooth means atrial flutter. In this instance, this is flutter without variable conduction. So in our previous episode, we talked about AV flutter with variable conduction, where the ratio between flutter waves and QRS was inconsistent. This is a very similar situation, but in this case, there is a consistent block pattern. So in this particular EKG, it's a 4-to-1 block. You can see that for every 4 intervals of where the flutter wave is at, there's 1 QRS. And so that's where we come up with that 4-to-1. In this case, treatment is pretty much the same as when we talked about in the last video. and also very similar to atrial fibrillation in the sense that if you need to do rate control, you can use beta blockers or diltiazem. Oftentimes in flutter, there is a particular nidus that we can ablate, and so radiofrequency catheter ablation is very commonly used. And beware, antiarrhythmics can make this worse, so be cautious about that and talk to your cardiologist. And then if this is sustained, if you're not able to fix the underlying cause, they do need to be anticoagulated to lower their stroke risk, similarly to in atrial fibrillation. So here's our big, daunting chart. Now that we've gone through this, hopefully this is a little less intimidating. And just remember, when you see a narrow complex tachycardia, ask yourself the 3 big questions. Is this regular or irregular? What is going on with the P waves and the isoelectric line? What is the pattern of the conduction? If you can answer those 3 questions, you can figure out what arrhythmia is going on with your patient, and you can treat them appropriately. Lastly, here are references. If you have any questions, please email us at info@decodingdx.com. We would love to hear from you. Thank you so much for joining us, and we'll see you next time.